Accept. Oh, I mean, what is the
Very good afternoon. Thank you everyone for joining us today. Today we shall be discussing about some aspects of the clinical diagnosis and management of neonatal seizures. I'll try and begin with a case scenario, and then we'll try to discuss various aspects of the etiology, pathogenesis, diagnostic modalities, and something about the newer advances in the treatment of neonatal seizures. Okay. So let's begin with a case scenario. We have with us a full-term 37 weeks, 3,100 grams male neonate born to a primigravida mother by emergency LSCS following meconium stain liquor. The baby had fetal distress in the form of fetal tachycardia and was born depressed with ABGA scores of 3, 5, and 7 at 1, 5, and 10 minutes of life. The baby required resuscitation in the form of positive pressure ventilation that was given for a total of 6 minutes, following which the baby developed spontaneous respiration, and on examination, the baby is noted to be floppy. The cord arterial pH is 6.9, which is suggestive of severe acidosis with base excess of -20, indicative of severe metabolic acidosis, and elevated lactate at 15 millimoles per liter. The baby is noted to have neonatal encephalopathy in the form of altered sensorium and excessive irritability. So this baby develops respiratory distress at around 15 minutes of life. The baby is noted to have a respiratory rate of 65 per minute with retractions, having a Silverman score of 4/10. The baby is initiated on humidified heated high flow nasal cannula at flow rate of 4 liters per minute with an FiO2 requirement of 30%. The baby is also noted to have normal heart rate with poor perfusion. The heart rate is 120 per minute with weak pulses and prolonged capillary refill time of 4 seconds, and is initiated on dobutamine at 10 mics per kg per minute. The blood pressure is 60/31, which is just above the 5th centile, indicating compensated shock. This baby develops repeated seizures at 3 hours of life and is managed with a loading dose of phenobarbital followed by levetiracetam, and develops respiratory failure with repeated apnea requiring mechanical ventilation at 36 hours of life, and is initially started on SIMV mode of ventilation. So I'll stop here with the case presentation, and let's have So I hope you're all able to see the video as well. So this baby is now having multiple clonic jerks involving the bilateral lower limbs as well as left upper limb. and this is also associated with bradycardia, with tachycardia and desaturations. So this case was discussed to kind of give a clinical background to what we are going to discuss today. And we all know that neonatal seizures are a clinically significant problem, both in terms of incidence and in terms of subsequent morbidity and mortality. Seizures in the newborn generally differ from seizures in children and adults, not only by their clinical appearances. For example, subtle seizures are prevalent in the neonatal age group and can account for close to 50% of all neonatal seizures, but these are generally non-described in pediatric and adult age group. And they also differ, neonatal seizures also differ from pediatric or adult seizures in terms of their electrographic characteristics. There could be some types of seizures, for example, generalized tonic seizures, and up to a half of myoclonic and subtle seizures, which may not have electroencephalographic corresponding abnormalities. There could be varied etiology, particularly hypoxic ischemic encephalopathy, accounting for a vast majority of neonatal seizures. The newborn brain also differs from the other age groups in terms of inherent excitotoxicity of the immature neurons. Of course, these differences also pave way to differences in the management of neonatal seizures and subsequent prognosis or outcome. So the importance of neonatal seizures can be understood from the fact that the occurrence of seizures in the neonatal age group is associated with significant mortality. So up to 16% of term newborns with seizures and up to 42% of preterm neonates with seizures may succumb either because of the underlying etiology that led to the neonatal seizures themselves or because of associated comorbidities. A large proportion of babies may evolve into subsequent postnatal epilepsy, up to 30% in term infants and 48% in preterm infants. There could also be a huge burden of subsequent cerebral palsy in those who have had neonatal history of neonatal seizures, not only motor disability, but also intellectual disability. And the incidence of overall abnormal neurodevelopmental outcomes can be 9 times more if the duration of seizure lasted for more than 40 minutes. So we'll go back to the classification of neonatal seizure. This is from the Volpe's textbook of neonatal neurology. So there are 4 classical types of neonatal seizures, starting from subtle, clonic, myoclonic seizures, and tonic seizures. Now, subtle seizure is a very characteristic type of neonatal seizures, which is characteristically seen only in the newborn age group. Subtle seizures define those type of seizures which may not be associated with clinically evident or clinically overt abnormal movements or abnormal phenotypic patterns, but they may be in the form of subtle ocular, oromotor, orobuccal lingual, autonomic or limb movements, and these may not be classically under the characteristic type of subsequent pediatric seizures. So there can be various types of subtle seizures, starting from ocular seizures. So we may have persistent conjugate deviation of the eyes to one side, or there could be persistent staring look of the eye, persistent tonic deviation, or conjugate gaze of the eye, as well as persistent staring of eye are the 2 characteristic patterns of ocular type of subtle seizures. There may be oral, buccal, and lingual type of subtle seizures in the form of lip smacking, tongue thrusting movements, or sucking movements. There could be autonomic variations, especially in the form of epileptic apnea, and the characteristic pattern in apnea due to seizures being the coexisting tachycardia, as different from bradycardia that usually occurs with typical apnea, non-epileptic apnea. If it is due to epilepsy, then it is accompanied by tachycardia. There could be limb movements like cyclical movements or rowing movements, fisting movements, and there could be just autonomic disturbances, especially in the form of tachycardia sometimes, that can be only identified if there is a continuous EEG monitoring that is also happening. So the EEG correlation with subtle seizures is up to the tune of 50%, which means 50% of the times subtle seizures may not be associated with EEG correlation. The second and the most common clinically overt type of seizure in newborn is clonic seizures, which is characterized by repetitive jerking movements involving the limbs, either upper limb or lower limbs, and sometimes both. And this is different or distinct from jitteriness, which is a normal type of movement. So clonic jerks typically come with a rapid and a slow component, a faster component and a slower component, and this would be variable in the amplitude. They tend to be at a frequency of 1 to 3 jerks per second, and usually are kind of slower than the frequency of jitteriness. Jitteriness, unlike clonic jerks, would be equal in the amplitude in both directions, whereas in clonic seizures, we typically see that there is asymmetry in the amplitude. So there is a fast and a slow component, and the speed, the velocity at which the movements happen also tend to be slower with clonic seizure. This could be either unifocal, which might involve just one limb, like you may have clonic jerks involving the left upper limb, or there could be multifocal. So there could be synchronous movements involving more than one limb. For example, there could be involvement of left upper limb and right lower limb, or vice versa. It is to be noted that the typical Jacksonian march, which is the slow stepwise progressive involvement of a larger and larger proportion of the limb, as can be seen in bigger children, is actually characteristically absent in newborn babies. And what we end up seeing is simultaneous involvement or multifocal clonic jerks rather than the typical Jacksonian march. So we have unifocal or multifocal clonic seizures. So these are quite commonly associated with EEG correlation. So that's very characteristic, and clonic jerks have excellent EEG correlation. Myoclonic jerks, on the other hand, are characterized by rapid and isolated jerks, typically involving the flexion movement, and the rapidity of the movement would be almost like a lightning kind of jerk, and usually involve largely a whole portion of the limb. So, for example, there might be lightning-like jerk of the entire hand in a flexion-like movement, as against clonic jerks, which involve a smaller portion of the limb, and they may be repetitive, smaller velocity jerks, in contrast to the lightning-like movement of myoclonic jerks. Again, myoclonic seizures can either be focal or multifocal or generalized. And EEG correlation is more common in generalized myoclonic jerks and is uncommon with focal myoclonic jerks. The last and relatively uncommon and controversial type of neonatal seizures is tonic seizures, characterized by stiffening of the whole body and characteristic posturing, either decerebrate or extensor posturing, and or it could be in the form of focal stiffening of a particular limb. And again, EEG correlation is common with focal tonic seizures and is almost always absent in generalized tonic seizures. So one needs to note that in up to 50% of neonatal seizures, EEG correlation may actually be absent. So this is what we discussed was a wall-based classification of neonatal seizures. We have some other systems of classifying neonatal seizures with some degree of overlap. So this video is a characteristic type of multifocal clonic jerks. We can appreciate how the baby is having isolated jerks involving both upper limbs, and when the video began, there were also some twitching of the facial muscles that were noted. So you can see that this does not really follow a progressive Jacksonian march kind of pattern involving from one part of the body to the entire body, or a partial extent of the body, but it occurs as synchronous involvement of multiple parts of the body concurrently. And this is a video showing a baby having a generalized tonic seizure, and we can appreciate that the baby is having a tonic extensor posturing of both the upper limbs and the upper half of the trunk, and this is accompanied by tachycardia, some frothing from the mouth. So having understood the various types of neonatal seizures, one needs to understand that seizures themselves in newborn, typically identified as paroxysmal alterations of the electrical activity of the brain, and that can be accompanied by motor, behavioral, and other autonomic dysfunction, can be either the clinical seizures or electrical abnormalities only type of seizures. So we have either clinically evident seizures, or we have seizures which are not clinically evident but are only electrographically identifiable. Now, in the clinical forms of seizure or epileptic seizures, we can either have seizures which are associated with electrical disturbances or electrical abnormalities, or those which do not have corresponding EEG seizures. So these are the different types of seizures when it comes to the clinical versus the electrographic seizures. And when we try to understand why neonatal seizures are so prevalent, or why seizures are more common in neonatal age group than subsequent age groups, one needs to go back to pathophysiology to understand that the neonatal brain has enhanced excitability because of the presence of more synapses and dendritic spikes. Also because of the physiological predisposition, where there appears to be a greater proportion of excitotoxic or glutamagic neurons that are abundant. And even the inhibitory neurotransmitters like GABA serve as excitatory neurotransmitters in the neonatal age group because of some unique characteristics of the neonatal neurons. So here we can see this is an excitatory or glutamagic presynaptic button, which is emitting the excitatory neurotransmitter glutamate, which in turn through the various glutamagic receptors like NMDA, AMPA receptors, results in depolarization or intake of sodium or calcium ions, cations into the cell, resulting in depolarization. So this results in excitation of the neuron. Now, in addition to the fact that the excitatory neurons themselves predominate in the neonatal brain, which is one reason for predisposing the neonatal brain to excitotoxicity, the other reason is that the GABAergic neurons, which are otherwise said to be inhibitory, also become excitatory in the neonatal age group, because what happens is the GABAergic channels, which are nothing but the voltage-gated chloride channels, the NKCC1 and the potassium 2 chloride channels, usually subserve to allow the inward entry of chloride, which is a negatively charged ion, which is generally expected to result in hyperpolarization. So this results in an inhibitory action typically on the neuron. But in the neonatal brain, because of the increased intracellular chloride channels, the GABA channel ends up letting intraneuronal chloride exit the neuron. Because of the inherently high intraneural chloride concentration in neonatal neurons, the GABAergic channels result in exit of chloride from the neonatal brain, resulting in paradoxical depolarization or excitotoxic action. And this also predisposes to the inherent tendency for neonatal brain to have a higher threshold for a lower threshold for seizures, or a higher tendency for seizures. So this is a graph that depicts that during this vulnerable age of starting from around few weeks prior to birth until the age of around 1 to 2 years, this is a critical period of activity dependent synaptogenesis and plasticity, where we also seen that there seems to be a predominance of excitotoxic function. This is because of the predominance of glutamagic channels, which are excitatory in function, and also because the GABAergic channels also become paradoxically excitatory because of the inherent increase in intraneural chloride concentration in the neonatal neurons. Now, we might wonder what are the consequences of this slightly higher predisposition to seizures in the neonatal age group, and what can be the ramifications of repeated seizures in newborns. So, repeated seizures, although per se, they indicate a sign of an underlying neurological dysfunction, which could be either HIE or hypoglycemia or other metabolic issues like inborn errors of metabolism or structural disorders. We also need to understand that seizures themselves can significantly contribute to morbidity arising out of hypoventilation or apnea during the seizure, which can result in abnormalities in gas exchange, hypoxia, and hypercarbia, which in turn can lead to cardiovascular collapse and decreased cerebral blood flow, fluctuations in cerebral blood pressure leading to a tendency to intracranial bleeds and brain injury, and finally, the resultant energy deprivation or loss of high energy phosphates leading to decline in ATP and increase in adenosine diphosphate. resulting in increased anaerobic glycolysis and lactic acidosis and deprivation of the supply of glucose to the growing brain. All these processes resulting in augmenting brain injury, ultimately involving excitotoxic amino acids and excitotoxicity as a pathophysiological mechanism. So repeated seizures can also increase the neurological morbidity by enhancing a cascade of neuronal injury. In addition to the direct clinical effects such as hypotension, hypoglycemia, and hypoxia, the major effects of recurrent seizures also include synaptic reorganization of axons and terminals in hippocampus, loss of dendritic spines in hippocampus, and increased susceptibility to subsequent epilepsy and impaired cognitive function. So now, having understood the different types of neonatal seizures and the underlying predisposition of the neonatal brain to seizures, let us now try to understand the different causes of neonatal seizures based on the postnatal age of appearance of seizures. So in the first 24 hours or within day 1, seizures are usually secondary to hypoxic ischemic encephalopathy or perinatal asphyxia, not just at the time of the birth, but this could also arise from an insult that is arising just before birth or antepartum hypoxia. Early seizures in the first 24 hours could also arise because of CNS and intrauterine infections, particularly the TORCH group of infections. Drug withdrawal, particularly maternal opioid withdrawal effect. Vascular etiology seizures, vascular onset seizures like neonatal stroke, typically the onset of which would be slightly delayed when compared to seizures because of due to birth asphyxia. So if we assume that most of HIE related seizures would be seen between 6 to 12 hours, stroke related seizures might be seen in the second half of the first day, that is between 12 to 24 hours. Seizures due to birth trauma, like seizures secondary to intracranial bleeds, could also be seen within the first 24 hours, or intraventricular hemorrhage in preterm newborns, pyridoxine-dependent seizures, and seizures secondary to inadvertent injection of local anesthetic in the scalp. In 24 to 72 hours, seizures may arise because of cerebral dysgenesis, that is structural abnormalities in the brain like lissencephaly, porencephaly, etc., schizencephaly, etc. We will continue to see seizures because of vascular problems, that is stroke, neonatal stroke. Metabolic seizures may commonly be seen between 24 to 72 hours, which include seizures due to hypoglycemia, hypocalcemia, and this could also be the phase where we may expect seizures because of inborn genetic metabolic errors, such as urea cycle disorders and organic acidemias, and we may still see seizures due to drug withdrawal pyridoxine dependency. Now, getting the history of seizures within 24 to 72 hours, I must say, may not rule out seizures due to HIE, because it's often seen that in the first 24 hours, seizures may be of subtle nature, and it may have sometimes got missed unless and until the baby was being monitored very closely with a high degree of anticipation for neonatal seizures. It is possible that seizures in the first 24 hours may be missed, and hence the baby with HIE related seizure may present to us for the first time at 48 hours. So this doesn't mean that it excludes HIE as an etiology entirely. Now, beyond 72 hours or beyond day 3, seizures may be due to some of these causes that we already discussed, but in addition, we may also need to consider and rule out familial neonatal seizures, benign familial or benign non-familial, benign idiopathic neonatal seizures. These are two different epilepsy syndromes that arise at this age. Cerebral malformations and infarction, and hypocalcemia, late onset hypocalcemia secondary to hypoparathyroidism. We continue to see seizures because of vascular events, and we start seeing seizures due to venous events like cerebral sinovenous thrombosis or venous hemorrhage at this stage, and also seizures secondary to severe hyperbilirubinemia and bilirubin encephalopathy or kernicterus. We may continue to see seizures due to IEMs that may present a little later. Organic acidemias, amino acidopathies, urea cycle disorders may continue to present at this stage, and seizures as a part of neurocutaneous disorders like tuberous sclerosis. Now, if we have to put the importance of various etiology in terms of a ranking of importance or of frequency of occurrence, HIE-related seizures, hypoxic ischemic encephalopathy-related seizures, by far account for the largest proportion of neonatal seizures as a whole, accounting for up to 50% of seizures. This would be followed, again, not in consistent order, by intracranial bleeds, vascular onset neonatal seizures, seizures due to cerebral malformations, infections including meningitis, septicemia, torch infections, and metabolic seizures, particularly hypoglycemia, hypocalcemia, and inborn errors of metabolism, and seizures secondary to maternal drug withdrawal. So this slide again kind of reiterates the same message and again brings in the point that HIE-related seizures account for by far the maximum proportion of neonatal seizures as a etiological group, followed by neonatal stroke. So now how do we assess or evaluate a newborn who is coming to us with seizures or a newborn who presents with seizures? So, of course, the importance of history cannot be understated, even though we have an entire armamentarium of diagnostic interventions that are available to us today, the importance of history. So, the clinical history would provide important clue for the etiology and the subsequent management. So, this starts from the age of onset of seizures, the semiology of seizure, the type of seizure, whether it was subtle versus clonic versus tonic, and the frequency, the number of episodes. Now, in addition to the clinical evolution of seizure, one also would like to see whether seizures were associated with significant disturbance in the sensorium, which is often referred to as encephalopathy. So, whether this was associated with encephalopathy or not. And one would also look into certain aspects of the baby's activity, particularly the feeding history, to understand how the baby's sensorium behaved in the first few hours prior to the onset of seizures. The presence of family history of seizures may suggest an underlying genetic epilepsy syndrome, and some of these syndromes are likely to be benign and may not always indicate a uniformly poor neurological prognosis. And in the absence of all other etiology, family history of seizures may actually suggest a relatively good prognosis. Now, in terms of antenatal history, history of maternal drugs that were taken during pregnancy, history that may indicate torch infections during pregnancy, such as the history of presence of maternal rash, lymphadenopathy, or fever during early pregnancy. History of risk factors for early onset sepsis in the peripartum period, such as history of prolonged rupture of membranes, maternal fever, foul-smelling liquor, the presence of maternal or fetal tachycardia during labor may be very important for considering the possibility of early onset sepsis with meningitis. Any antenatal ultrasound abnormalities also may be an important clue to consider the possibility of CNS malformations. The presence of fetal distress, particularly fetal bradycardia or fetal tachycardia, or absence of fetal heart rate variability, and the presence of maternal morbidities like preeclampsia and maternal infections may be valuable clues for understanding what could be the likely etiology. So the presence of fetal distress may be an important pointer towards hypoxia as a possible etiology of seizures. When it comes to the natal history, it is very, very important to understand the mode of delivery, the duration of labor, and all the antecedent preceding events. Some of these could be important sentinel events like the presence of cord accidents or placental events. The extent of resuscitation or the duration of resuscitation that was required, the Apgar scores, and the cord blood gas, especially the pH, metabolic acidosis, and lactic acid levels, to understand the extent of perinatal hypoxia. Now, low Apgar scores, but without the need for resuscitation and subsequent neonatal intensive care, again, is unlikely to be associated with neonatal seizures. So unless the history of asphyxia is substantiated with history of substantial resuscitation that was required in the form of need for positive pressure ventilation or need for intubation, the need for subsequent intensive care management, and the need for therapeutic hypothermia, etc., as a low Apgar score alone may not be sufficient clue for making a diagnosis of asphyxia as an underlying etiology for seizures. When it comes to the clinical examination, there could be some important clues that may arise from the examination of the baby. So one would start by looking at the head size, the head circumference, as well as any abnormalities in the shape of the head. So for example, microcephaly or the presence of head circumference less than -2 standard deviation can be associated with some metabolic disorders like the glucose transporter 1 deficiency or certain urea cycle disorders, serine biosynthesis defects, etc. The presence of dislocation of the lens, which can be detected by a careful ophthalmological evaluation, can be indicative of sulfate oxidase deficiency or molybdenum cofactor deficiency. The presence of skin and hair changes, the presence of dermatitis and alopecia can be a clue for biotinidase or multiple carboxylase deficiency. We may see some characteristic dysmorphic facial features, which could throw a clue to an underlying metabolic issue. Like there could be characteristic appearance in conditions like Zellweger syndrome, which could be a valuable clinical marker for the underlying etiology for neonatal seizures. Neurocutaneous markers, particularly in a baby with, say, suspected tuberous sclerosis, the presence of ash leaf macules and typical skin changes could also be an important or valuable clue for us to suspect what could be the etiology for neonatal seizures. Of course, in addition to all these specific markers, one needs to do a detailed neurological examination to understand whether neonatal seizures were associated with abnormalities in the tone, which includes both assessment of the active as well as the passive tone, and for the presence of other organ system involvement, like the presence of a murmur in the cardiovascular system, which could indicate an associated cardiac defect, congenital heart disease, or could be secondary to tricuspid regurgitation, which could be a part of the spectrum of asphyxia, and for presence of organomegaly, particularly hepatosplenomegaly, which can be an accompanying feature in some of the inborn errors of metabolism. So in addition to the clinical clues, one has to understand that with the best of clinical examination, the clinical identification of seizures itself has only an accuracy of around 50%. So the utility of a conventional EEG as a gold standard for defining an identification of seizures has now been backed by a lot of professional bodies. The American Clinical Neurophysiology Society suggests strongly a conventional EEG, if possible, video electroencephalogram for identification or for diagnosing paroxysmal events, which are at high risk for seizures, as a gold standard for the diagnosis of seizures. Now, amplitude integrated EEG as against a conventional EEG is associated with lower sensitivity and lower specificity than conventional EEG. And although it may not be sensitive and specific for detecting every seizure, particularly focal seizures in newborns, focal, brief, and distal seizures, it may have a good sensitivity for the diagnosis of status epilepticus. When it comes to the laboratory evaluation of a newborn baby developing seizures, some important first-line investigations would include ruling out hypoglycemia by doing blood glucose levels, serum calcium to rule out hypocalcemia, serum magnesium to rule out hypomagnesemia, electrolytes, sodium, potassium, and chloride, generally to rule out disturbances in the electrolyte levels like hyponatremia and hypernatremia, a blood gas to look for metabolic acidosis, sepsis screen. As per the unit policy, there could be different components which could be a part of the sepsis screening. We know that sepsis screening, when performed at a gap of 24 hours and when 2 screens are negative, has an excellent negative predictive value for ruling out sepsis. As a part of the second line blood workup for seizures, one might have to consider a metabolic workup, a basic metabolic workup, which typically includes serum ammonia levels, lactate levels. This may be accompanied by urine ketone evaluation. A blood glucose and anion gap would generally be available even from the first tier investigation. In those babies where one does not have a clear-cut etiology from these first tier of investigations, a CSF analysis becomes an essential part, because neonatal meningitis may sometimes not be accompanied by overt features of infection or by a positive sepsis screen. So we must have a very low threshold for performing CSF analysis in those babies with neonatal seizures that may not be due to clearly an obvious etiology like a HIE-related seizure. Metabolic workup again forms an important component for newborns presenting with slightly delayed onset seizures, particularly after a period of breastfeeding has been provided to the baby. So after 24 to 48 hours, when the baby presents with encephalopathy and persistent or repeated neonatal seizures, one needs to have a high index of suspicion for IEMs. And to rule out which, we may have to resort to a blood tandem mass spectroscopy and urine GC-MS. We'll discuss a little bit about neuroimaging as well. So this is an algorithm for the etiological evaluation of a newborn with seizures and summarizes some of the things we have already discussed. So in addition to the basic blood profile or the first line blood profile, which would include blood glucose levels, serum electrolytes, blood gas, a full blood count differential and C-reactive protein as a part of sepsis screen and blood culture. One may have a very low threshold for performing CSF analysis to rule out meningitis. And a basic head ultrasound at least would be an essential part of etiological workup in a baby with seizures. The need for a higher imaging like a magnetic resonance imaging may have to be taken on an individualized basis. A continuous video EEG remains gold standard for the diagnosis of neonatal seizures, and this is because of the poor accuracy of clinical assessment for the detection of seizures, and this could be as poor as 50%. So continuous video EEG not only helps us to detect the electrographic only seizures or subtle or the non-clinically overt seizures, which could be commonly seen with preterm infants with seizures or with the hypoxic ischemic encephalopathy. But EEG may also give us important prognostic information in terms of the long-term outcome and may also be useful for deciding the duration of anti-epileptic therapy. Now, in terms of the subsequent evaluation, so I'll go back to this index case that we discussed in the first slide. We had seen a term, good weight baby presenting with neonatal seizures at 3 hours of life. So this baby's blood glucose levels, which were done at the time of seizure, 6 and 12 hours of birth, were all consistently normal. And the baby had an essentially normal sepsis screen, except for the elevated white cell count of 22,300 per cubic millimeter and raised C-reactive protein at 12 milligrams per deciliter. The baby had a normal serum calcium, the range being 8 to 10 milligrams per deciliter. It was 9.5. Electrolyte levels suggested a slightly reduced serum sodium at 134 milliequivalents per liter, normal potassium, and neurosonogram revealed mild effacement of lateral ventricles, which could be an indicator of cerebral edema, and there was no evidence of intracranial bleed. So this case that we have just discussed, where there was a background history of perinatal asphyxia with a cord blood gas showing severe metabolic acidosis, if you may recall, and the baby presenting with very early onset seizures at 3 hours of age, looks like a classical case of HIE-related seizures, and most of the other workup has turned out to be essentially negative. A slightly elevated C-reactive protein and white cell count can very well be associated with birth asphyxia itself. So neuroimaging with MRI was done in this newborn, and the best time for performing the MRI in newborn with HIE-related seizures may be at something around day 5 to day 10, which is the time at which we get the maximum sensitivity as well as maximum specificity of magnetic resonance imaging in HIE. And we know that very early MRI may miss some of the changes due to hypoxia, and perhaps at around 48 hours, the MRI may be diagnostic only when accompanied by a diffusion weighted imaging. And also beyond around 10 to 15 days, the diagnostic utility of the MRI or the sensitivity might come down significantly. So we typically prefer to do MRI between 5 to 10 days of postnatal age. And this baby's MRI showed abnormal signal hypointensity in the T1 weighted MRI images in the posterior limb of the internal capsule, as well as within the thalami and the basal ganglia. And the same regions were found to be hyperintense on the T2 weighted imaging, typically as would be seen in hypoxic ischemic encephalopathy. So this was a case of demonstrating HIE changes where MRA turned out to be helpful. The neuroimaging with MR is also useful with CNS malformations such as focal anomalies like polymicrogyria, heterotopia or cortical dysplasia, or with hemispherical involvement as seen in hemimegalencephaly, or with lissencephaly, where we would find diffuse flattening or ironing out of the sulci and gyri. So these are some images of the above three conditions. And this is a baby with a huge porencephalic cyst, and this baby seems to have a schizencephaly with a cleft-like appearance in one side of the brain. So in addition to HIE seizures, metabolic, infective seizures, seizures due to intracranial bleeds, stroke, as well as CNS anomalies, we also sometimes encounter neonatal epilepsy syndromes. So once we have ruled out most of the primary etiological evaluation, wherein the baby does not fit in with seizures due to any of these classical etiology, such as HIE, metabolic seizures, including hypoglycemia, hypocalcemia, and inborn errors of metabolism, CNS malformations, stroke, and when most of the workup comes back negative and the newborn continues to have persistent seizures, one may have to consider the possibility of neonatal epilepsy syndromes. And two common benign types of neonatal epilepsy syndromes include the benign familial neonatal epilepsy and the benign non-familial or benign idiopathic neonatal epilepsy. So BFNC and BINC, as they are usually referred to. Now, benign familial neonatal epilepsy usually presents with seizures, usually from the second or third postnatal day, and most of the seizures are focal tonic or focal clonic or apneic seizures, and they may self-limit with seizures gradually subsiding by 1 to 12 months of age, and only 10 to 15% of these newborns evolve into subsequent epilepsy. Some of the genes involved are indicated in the slide. The other type, which is benign non-familial neonatal epilepsy, where you don't find family history of neonatal of seizures, is the benign idiopathic or non-familial neonatal epilepsy, where EEG shows the characteristic theta 0.2 alternate, which is a characteristic EEG pattern in EEG. And when we do CSF analysis, one generally finds low zinc levels. This condition is also called as fifth day seizures, and generally the newborn might present with seizures from day 5, and they continue to have persistent seizures, but they again may have a relatively good long-term outcome. The other relatively malignant type of neonatal onset epilepsy syndrome is Ohtahara syndrome or early infantile epileptic encephalopathy, which again presents with recurrent tonic seizures in the first week of life, but can subsequently evolve into myoclonic seizures. And usually the imaging of the brain shows structural cerebral lesions. And EEG would also be abnormal, showing severely abnormal patterns like the burst suppression or Hips arrhythmia pattern. And again, these have also been linked to underlying genetic mutations in a percentage of the involved infants. And Ohtahara syndrome is generally associated with a relatively poor neurological prognosis. The other type of seizure is usually neonatal seizure that is arising as a result of inborn genetic errors of metabolism. Now, when does one suspect that seizures could be due to IEM? So if you encounter recurrent or refractory seizures, which are relatively unexplained by the primary workup, so we don't have history of HIE, there is no evidence of sepsis, and CSF examination possibly done is normal or not suggestive of meningitis, and it looks like the imaging is also normal. These are the cases where we typically think of seizures secondary to IEM, and seizures that can be related to fasting or stress or illnesses may also make one suspect seizures due to IEM. There could be episodic history of vomiting or diarrhea, dehydration, and persistent feeding problems and parental consanguinity. There may or may not be positive family history of associated seizures. So the goals of treatment in IEM would be the goals of treatment in neonatal seizures may be usually to sort of identify and abolish electrographical seizures and to identify the etiology and to treat the etiology, and also to prevent secondary brain injury. So let's go through the pathway of treatment of neonatal seizures. Of course, this is a relatively older pathway taken from the AIMS protocol. There are some newer algorithms that are also evolving. Now, once one has identified neonatal seizures and characterized the type of seizure, it is important to secure the airway and optimize breathing, circulation, and temperature. So, the management of any clinical syndrome, including neonatal seizures per se, would begin with establishing TABC, which is temperature, airway, breathing, and circulation. So, optimize the temperature, provide warm care if the baby is hypothermic, maintain a body temperature in the euthermic zone of 36.5 to 37.5 degrees Celsius, optimize breathing, provide appropriate respiratory support as may be required. Say for a baby with respiratory distress, one has to start CPAP, or maybe in a baby with hypoxia with good efforts, maybe consider starting oxygen. There may be a baby with seizures and apnea who may actually require ventilation as well. So optimize breathing, circulation, assess the baby's heart rate and circulation, and stabilize the baby by use of volume bolus or appropriate inotrope therapy as might be indicated by the clinical status. It is important to secure a safe peripheral intravenous access, and if possible, use an intraosseous access wherever IV access is difficult to obtain. Taking samples for basic baseline relevant investigations like sugar, calcium, magnesium, sodium, potassium electrolytes, blood gas, hematocrit, and sepsis screen. If the baby is hypoglycemic with a blood sugar of below 40 milligrams per deciliter, the newborn needs to receive intravenous bolus of glucose at the rate of 2 ml per kg of 10% dextrose. That should be given immediately. And this should be followed by a glucose infusion rate of 6 to 8 milligrams per kg per minute. If the blood sugar is within the normal range, one has to take a sample for ionized calcium, and this should be withdrawn. The ionized calcium sample should be withdrawn, and 2 ml per kg of calcium gluconate 10% should be given IV under close cardiac monitoring over 10 to 15 minutes. It is also important to take a brief history concurrently while the management is going on, and perform a quick clinical examination. This includes taking history for the antenatal, natal events, and performing a quick clinical examination to assess the overall hemodynamic and respiratory status, and to get potential clues about the underlying etiology. Now, if seizures persist despite the above two steps, can one of you come here? One has to start a loading dose of phenobarbital 20 milligram per kg stat, that is given over 20 minutes. If seizures continue despite phenobarbital, and a repeat dose of phenobarbital at 10 milligram per kg dose is recommended until we reach a total dose of 40 milligram per kg. I shall be discussing just in a moment about the controversies in the choice of the first anti-epileptic drug for the treatment of neonatal seizures shortly. But this is as per the existing protocol now. We still believe that phenobarbital remains the first choice of drug when it comes to the management of neonatal seizures, as endorsed even by a very recent Cochrane review. So phenobarbital could be repeated at mini bolus doses of 10 milligram per kg per dose, given at a rate of not crossing 1 mg per kg per minute to a maximum of 40 milligrams per kg. And if seizures persist despite this dose of phenobarbital, one would use phenytoin, which remains a second line agent, at a dose of 20 milligram per kg per dose, given as a loading dose, and repeated to the tune of 10 milligram per kg per dose. Now, if seizures stop at this point of time, then well and good. But if seizures continue despite these two drugs, one will have to consider the subsequent third-line drug, which would be a loading dose of lorazepam or midazolam, which is given at a dose of 0.2 milligram per kg. And one may have to consider the use of midazolam infusion if refractory seizures. Consider ventilation if the baby goes into respiratory failure because of high dose of midazolam infusion. And if seizures continue the above three drugs, one may have to consider the use of other anti-epileptic agents like pyridoxine, and even the use of exchange transfusion as the last resort. The expected response to the first 20 milligram per kg dose, loading dose of phenobarbital for cessation of seizures is generally to the tune of 40%, which means 60% of the times the seizures may continue despite the loading dose of phenobarbital. When the maximum loading dose of 40 milligram per kg has been used, seizure control achieved reaches the tune of up to 70%. 85% of seizures may abate with the loading dose of the second line anti-seizure drug, which is phenytoin, given at 20 milligram per kg. The seizure control in the remaining proportion of babies who typically will qualify for refractory drug-resistant seizure, which means seizures continuing despite the maximal doses of two different anti-epileptic drugs, generally would require doses of benzodiazepines, either lorazepam at 0.05 to 0.1 milligram per kg or midazolam at 0.1 to 0.3 milligram per kg loading dose, followed by the infusion. So this is based on a randomized control trial by Painter et al. That compared phenobarbital versus phenytoin as the first line anti-epileptic drug. It was found that the use of either phenytoin first versus phenobarbital first resulted in seizure control to the tune of 40 to 45% of seizures only. And in most of the babies, there was no significant difference actually between the use of either of the drugs. But phenobarbital, despite these very small differences, continues to remain the first line anti-epileptic drug. There have been number of newer randomized controlled trials that have compared levetiracetam, which is evolving as a very attractive or promising anti-epileptic drug, versus phenobarbital. Levetiracetam is usually used at a loading dose of 40 to 60 milligram per kg intravenously, and followed by a maintenance dose of 30 to 60 mg per kg per day, and has the advantage of not being associated with an increased risk of neuronal apoptosis and may be associated with neuroprotective effects. We also have bumetanide, which is typically inhibitor of NKCC1 receptor, and it is similar to furosemide, which is used as a loop diuretic. And because of the increased intracellular chloride concentration in neonatal brain and its paradoxical effects of this change on the GABAergic effect on the neonatal brain, bumetanide also continues to be a promising anti-epileptic drug by reducing the intracellular chloride concentration. Something about lignocaine, which has been recommended by some guidelines, particularly the World Health Organization guidelines on neonatal seizures, which recommends lignocaine as a second drug of choice as neonatal anti-epileptic. This is used at a loading dose of 2 milligram per kg over a period of 10 minutes, followed by an infusion at 6 mg per kg per hour. The one major side effect being cardiac arrhythmias. And hence, lignocaine can only be reserved as an anti-epileptic that can be used in an intensive care setting with continuous cardiac monitoring. And in case of cardiac arrhythmia, the infusion should be discontinued immediately, and lignocaine should never be given to a newborn with a congenital heart disease. This is a newer algorithm in the management of neonatal seizures. And although most of the steps that we have already discussed are kind of similar to what is mentioned in this algorithm, the only option that it also offers is that after one has loaded with up to 30 milligram per kg of phenobarbital, if one feels that the baby is more likely to require cardiovascular support or more likely to require ventilation, one may avoid the last loading dose of phenobarbital, which would accumulate to around 40 milligram per kg of cumulative loading dose, and one may resort to the use of levetiracetam at a dose of 20 milligram per kg loading dose in those newborns who are deemed to have high risk of requiring cardiovascular support. Now, in those seizures that are refractory to the first two anti-epileptic drugs used at maximum doses, one may resort to the use of midazolam infusion after a loading dose of 150 to 200 microgram per kg, which is 0.2 milligram per kg. One may use an infusion of 60 micrograms per kg per hour, which is 1 microgram per kg per minute. And if seizures persist, this may have to be increased to 5 times of the dose, which is around 5 microgram per kg per minute or 30 micrograms per kg per hour based on the presence of ongoing seizures. So this is something about the other anti-epileptics which we have already discussed. Just to complete our discussion, we must be aware that, of course, phenobarbital, despite its numerous advantages and despite being still preferred as the most preferred anti-epileptic in neonatal seizures, is associated with a significant risk of respiratory depression, decreased sensorium, decreased level of consciousness, hypotension, hypotonia, idiosyncratic skin rash, and hepatotoxicity. Whereas phenytoin and its analog phosphenytoin, the water-soluble analog phosphenytoin, may be associated with infusion site reactions, cardiac arrhythmias, and hepatotoxicity. So this is a Cochrane review that was published by an Indian group, Dr. Abhiramalata and team, who have recently come up with their Cochrane review on anti-epileptics for neonatal convulsions. And this is their summary of evidence of studies comparing phenobarbital versus levetiracetam as the first drug of choice for neonatal seizures. It is seen that the risk of proportion of infants who kind of achieve seizure control after the first loading dose of the anti-seizure medication. You can see that it's the risk with phenobarbital is 306 per 1,000 and the risk with levetiracetam is 443 per 1,000. So it seems to favor phenobarbital as the first drug of choice for neonatal seizures. In terms of supportive management, one needs to understand that one has to maintain physiological temperature, glucose, oxygenation, ventilation, and blood pressures. So these form an important component of the holistic management of neonatal seizures. And I shall conclude with the key recommendations from the World Health Organization. Okay, so one is as per the World Health Organization, the clinical seizures must be treated for if they are lasting for more than 3 minutes, or if there are brief serial seizures, if the cumulative duration is more than 3 minutes. Seizures that are associated with electrical abnormalities are also strongly recommended for treatment. It is recommended by the WHO that hypoglycemia should be ruled out and treated before one embarks on the use of anti-epileptic drugs. So there is a strong recommendation in favor of ruling out hypoglycemia and treating hypoglycemia if present before using the first anti-epileptic drug. Neonatal seizures must be accompanied by evaluation of serum calcium if facilities are available. And if facilities for immediate measurement of calcium may not be available, then one may consider treating hypocalcemia as well before using the first AED. There is also a strong recommendation in favor of performing a lumbar puncture. If clinical signs of sepsis or meningitis are present, it is strongly recommended that a lumbar puncture is done to rule out CNS infections. Phenobarbital is recommended as the first line agent for the treatment of neonatal seizures, although the WHO strongly recommends against the use of prophylactic use of phenobarbital in neonates with HIE. It recommends that whenever available, all clinical seizures should be confirmed by EEG. This is, of course, context specific and is relevant to those settings where continuous or video EEG may be available. And EEG should not be performed for the sole purpose of determining the etiology. So EEG, one must remember, must be performed for the purpose of confirming seizures or diagnosing seizures, and for the purpose of understanding the long-term outcome, and not for determining the etiology of seizures. Radiological investigations of the head or cranium should not be performed to determine the presence or absence of clinical seizures or to evaluate the efficacy of treatment with AED, and would purely serve the purpose of understanding the etiology of neonatal seizures. The WHO gives weak recommendations for considering empirical treatment with glucose wherever facilities for measurement of glucose are not available. So if one is not able to rule out hypoglycemia, like if glucose sticks or glucometer is not available in a certain setting, one may consider empirically giving the 2 ml per kg of dextrose bolus If facilities for LP are not available, one may consider empirical treatment with antibiotics to treat meningitis. And again, this is a context-specific weak recommendation. They also give a weak recommendation that seizures, when not abated after the maximum dose of phenobarbital, may be treated with lidocaine or midazolam as a second line of drug for controlling seizures. And one must note that the WHO does not go with phenytoin as a second drug of choice. It also gives a weak recommendation that in neonates with normal neurological examination and or normal EEG, one may consider stopping AEDs if seizure-free for at least 72 hours. The WHO recommends that in seizures controlled with single anti-epileptic drug, the drug may be abruptly discontinued without tapering doses. And if more than one anti-epileptic drugs were used, all other drugs can be stopped one by one, with phenobarbital being the last one to be withdrawn. And radiological investigations may be done as a part of comprehensive evaluation of etiology and not to determine the prognosis or the presence of seizures per se. So this was the discharge status of the index case that we started our discussion with. The term baby with birth weight of 3,100 grams. The baby was managed with 2 anti-epileptic drugs, of which one drug was abruptly discontinued after attaining 72 hours of seizure-free window. At discharge, this baby was actively sucking from the breast with mild pallor. Spontaneous, regular neonatal movements were present. The baby had eye movement, was tracking objects. The tone in the upper limb was slightly increased when compared to lower limb, and there was mild head lag on pull to sit maneuver. The discharge weight was 3,800 grams. And this is the algorithm for the plan for weaning anti-epileptics. So wherever possible, one tries to wean off all the anti-epileptics except phenobarbital once seizure-free period of 72 hours is reached. And when we are on a single anti-epileptic drug, perform neurological examination prior to discharge. If normal, even phenobarbital can be stopped abruptly prior to discharge. If discharge neurological examination is abnormal, one will have to continue phenobarbital for 1 month and then repeat the neurological examination. Again, if at 1 month neuro examination is absolutely normal, one can taper phenobarbital over 2 weeks and stop it. And if it is associated with persistently abnormal neurological examination, one needs to evaluate with an EEG. Again, if EEG is normal, the baby can come out of anti-epileptics over the next 2 weeks. If this is also accompanied by an abnormal EEG, one will have to continue the anti-epileptic drug and reassess at 3 months. So I thank everyone for joining us today on this webinar, and we'll be glad to take any questions which can be posted on the chat box or the comment section. Thank you very much.